Good.
Okay, so you can share your screen. I think we can start because we've got 1, 2, 3, 4, 5, 6, 7, 8, 9 people on now. So,
excellent. Okay.
So make a start.
Yep. Okay.
Okay, good evening, everybody. Welcome to this last lecture in this series. And we have Mr. Oshowo, who's going to talk to us about minimally invasive surgery and robotics. Mr. Oshowo is an IMSG member and is a consultant laparoscopic and colorectal surgeon at the Whittington Hospital, University College Hospitals, London. He has spoken to you before, I think, on colorectal cancer. So this is his second lecture, and I'm very grateful to listen and learn from the master. Ayo.
Thank you very much, Mr. Dedeji, and good evening, everyone. You probably see my screen, but for some reason, you're not going to be able to see my face, which is in the corner of the computer. So we're going to talk this evening about minimally invasive surgery and then go on to robotic surgery. So the scope really will be able to learn in this session about why we do minimally invasive surgery, which in essence is probably going to be limited to laparoscopic surgery. How do we do it? What cases are possible with laparoscopic surgery? And then how do you get started? How do you get started? And also from there on, we move to the robotic, which is a fairly new actually. Even in UK here, it's still new, and it's only done in few centers. By way of history, surgery is always about history. Somebody's done something in the past. Nothing is new. As you can see from this slide, what we term to be laparoscopic surgery actually started off as, hello?
Your slides are not moving.
You haven't seen history of laparoscopic surgery?
No, we still have the first slide on.
Okay, it should be. So you still have the first slide of surgical.
Yes, we still have minimally invasive surgery and robotics, that's all.
Okay. So it's saying you're sharing now.
Yes, we are viewing your screen, but it's not moving.
It's not moving at all?
No. Okay. What's it called? Make it fill the page, the lower button on the lower end of your screen, the right side.
It is full. It is full now.
So it's not here.
Okay, let me stop sharing and then. How about that?
Yes, that's full now.
Okay. So that's still the first page. Now I'm going to move to the second page.
Okay. Yeah, that's moved.
Excellent. Okay, good. Technology. So it will. we'll get to it in the end. So I was talking about the history of laparoscopic surgery, and as you can see from the slide, please again feel free to interrupt me if there is any problem with the slide. From the 19th century, you can see in Frankfurt, the first rigid endoscope was performed by Felipe to examine the bladder and the rectal and do a rectal examination. And since then, it's been done in Sweden, Switzerland, Turkey, basically throughout Europe. And it's now become what we know now to be laparoscopic surgery. So almost you can say that through a period of trial and error, doing it on various parts of the body, any orifice, any cavity, where you can pass instruments through has been tried. And I think the very good ones were performed to divide adhesions in the early years, in the 1933 and so on, until the gynecologists took hold of it and used it to perform a lot of tubal serialization. The first appendicectomy was performed by a gentleman called Sem, and I think he's a French guy. And then it moved on to cholecystectomy in 1987. So what we're talking about actually are still very, very, very new procedures. 1987 was the first lap chole. And I remember the United Kingdom did not start fully until 1990s. The advantages, basically the reason why everybody wants to do laparoscopic surgery. Again, you can see the new slide. Hello?
Yes, sir, we can see the new slide, sir.
Excellent, please. The reason why everybody wants to do laparoscopic surgery is because of the perceived advantages. So we know when you do keyhole surgery, we call it keyhole because the wounds are smaller. And when you have small wounds, then it is possible that the outcome will be better as long as you can perform the operation. So when you have a small wound, you have less pain, less metabolic response to injury, faster recovery, short hospital stay, and the patient is able to go home quicker. The proponents are quite good to tell you about all these advantages, but in the initial period, there were a lot of problems with mainly not because it was not able to, people were not able to perform the surgery, but because there were a lot of morbidity associated with laparoscopic surgery, which we call mainly off-camera injury. It is easy to damage internal structures if you're not very, very good at holding the camera or using the instruments. So it is possible to damage the bowel or even make a hole in the big vessel. It's been known that people create a hole in and they rupture aneurysm while performing laparoscopic surgery. And in oncology setting, it is also possible that you're not performing laparoscopic surgery completely in terms of clearing the cancer, because you cannot really feel the extent of the cancer when you're performing laparoscopic surgery. And also it is difficult to know sometimes where the tumor is. For instance, if a tumor is in the left colon and you don't know exact point, when you look at it through a laparoscope, you may not be able to see it properly. We will talk about that later, because now what we do is to inject the site with some tattoo, so that when you do the laparoscopic surgery, you can see the tattoo and the site is already marked. And also there were problems with extraction of the tumor or specimen. So you can imagine if you have small wound and you have specimens to take out, even appendix, it may be difficult to take out the big appendix through a small wound. Most of the wounds are like 5 millimeter or 10 millimeter. And you may then have to create a bigger wound in order to extract the specimen. You may also have to find a bag to put the specimen in, so that when you're taking out cancer, for instance, or infected specimen, you're not causing any contamination of the wound site. Initially, port site recurrence was quite high, but now all these things have been mitigated upon, because you can now put the specimen in a bag and take them out easily. So these were really initial problems, and it certainly put a lot of centers off from doing laparoscopic surgery. but as we know now, they're not problems anymore. And I will probably give you one or two papers to support this. While I'm there, actually, I think last week we were talking about laparoscopic. I understand Mr. Fuakwe and a few others do laparoscopic visualizes and appendicectomy. It's difficult for me to do a short snap audit. Are there any of the residents who have done appendicectomy laparoscopic? Or you can just say yes if you've done it. Nobody's done laparoscopic appendix? Has anybody assisted in laparoscopic appendicectomy?
Yes, nobody has done it, sir.
Okay, and nobody is assisting. Yeah. Okay, so it's not.
We have assisted, sir.
You've assisted, so it's not really a common practice as far as it goes. Then that's the impression I'm getting. Okay, I will take you through getting started on the next slides. But before we go to that, let's look at one of the perceived advantages of laparoscopic surgery. This is in terms of immune response. We all know when you do open surgery, you do laparotomy. What you do is creating a large wound, and in effect, a large wound. A large wound leads to increase in metabolic activity in the body. Basically, you've caused trauma, and the body responds to trauma by some immune mechanisms. So when you do that in open surgery, you are more likely to suppress the patient's immunity. And when the immunity is suppressed,
which kind of patient? Anybody assisted in laparoscopic surgery? Yeah.
Is that correct? Yeah.
Yeah, go on. I know somebody was just talking. I've muted the person.
Sure, thanks. Okay, so when you do laparoscopic surgery, it is perceived that you stimulate the immune response much less than when you do the open surgery. Therefore, the patient recovers quickly. If you're dealing with cancer, there is perceived benefit that the patient recovers quickly because you have not interfered with tumor growth, as demonstrated in this paper by Allendorf. Again, it was performed in mice, but it's really a good paper, and it encouraged most people to now see the perceived benefit of laparoscopic surgery over open surgery in eliciting less immune response than in open surgery, basically less trauma. The same thing with the second paper by Kamer et al., where patients who undergo open laparotomy, they have greater magnitude of trauma response to surgery. Again, in terms of disadvantages, we looked at the cost. As you know, it costs really little or nothing to have your standard knife and the scalpel, have the theater set up. But when you're doing laparoscopic surgery, you now have to purchase various other equipments like the laparoscopic equipment, the video, basically is in HD. You have to have theater personnel that are trained in it, and all these add up. So it is perceived that, again, it is more expensive doing laparoscopic surgery than open surgery. And I can see why it's still difficult to justify doing laparoscopic appendicectomy over doing open appendicectomy, because the cost of doing laparoscopic appendicectomy is definitely going to be more. But when you look at the benefit of doing laparoscopic appendicectomy with a small incision, and patient can actually have it as a day case, and over a period of time, when you do many appendices in that way, or let's say cholecystectomy, when you do many gallbladder surgery, the patients are able to go home same day. You have little or no wound-related problems. There's no wound infection, no incisional hernia, and the length of hospital stay is reduced. Then the cost is actually almost similar to the cost of open surgery, if not cheaper. The other disadvantage of laparoscopic surgery is that it takes longer. We know that when you do appendicectomy, a lot of you probably do appendicectomy in 15, 20 minutes, whereas the setup for laparoscopic appendicectomy in itself will probably be about 15, 20 minutes before you start doing the procedure. So it takes longer. But again, as time goes on, you find out the duration that it takes you to do the operation, it's about 20 to 60% higher in laparoscopic than in open surgery. But all these disadvantages are not as bad as when you look at the post-operative recovery and the quality of life of the patient after surgery. The other problem associated with laparoscopic surgery is in cancer surgery, where it is possible that you can seed tumors along the port site. Port site is where you've inserted your instruments. So when you extract the specimen, it's possible that the tumor can seed along the port site because of the insufflation from the gas. So a few papers have actually looked at recurrence rate from port site in open and laparoscopic surgery, and there's really they're not significant. Most centers where laparoscopic surgery are done routinely, the port site recurrence is less than 1%, which is nearly almost similar to what you get in open surgery. So it's not a common problem at all. And nowadays we use bags, we use a lot of techniques to make sure that the specimen are not in contact with the wound. In my area of expertise is in colorectal surgery. So we can perform virtually every colorectal surgery doing laparoscopy technique, from right colon, right hemicolectomy, left hemicolectomy, segmental colectomy, anterior resection. You can use it for cancer surgery. You can use it for benign, such as diverticular disease, inflammatory bowel disease, and also for functional problems like pelvic floor disorder, doing rectopexy. So essentially, you can use it for a wide range of procedures. And going away from colorectal, you can actually, it's been done in gynecology for ovarian cystectomy, hysterectomy, urology, they use it for nephrectomy, thyroid, endocrine surgery for adrenalectomy. So every abdominal surgery basically can be performed laparoscopically. Initially in the UK, there was a problem with acceptance of laparoscopic surgery in colorectal, laparoscopy in colorectal. because people thought that there were many disadvantages over the open surgery. And this led to a lot of randomized control trial. And the best of that is what we call the classic trial. And this was concluded in 2002, and that was when laparoscopic became acceptable in the United Kingdom. And all over the world now, we know that laparoscopic surgery has become the first choice operation when you're giving patients an option of surgery. So if you look at this paper by Abraham et al. In 2004, it was to look at the outcome after laparoscopic resection for colorectal cancer. There were over 2,000 patients randomized in 12 centers. Open surgery versus laparoscopic surgery. So as you can see from this paper, which was one of those papers that was widely read and accepted, the clearance that you get, there's something called surgical clearance, oncological clearance in cancer surgery. It's as good as in open surgery. Although it concluded that laparoscopic surgery takes longer to perform for obvious reasons. The setup alone is longer. However, the morbidity associated with laparoscopic surgery is lower. And the morbidity we're talking about really are wound-related. So you have a wound-related lower morbidity in laparoscopic than in open. Obviously, the blood loss is lower in laparoscopic. There's virtually little or no blood loss in laparoscopic surgery, because once there is bleeding in laparoscopic surgery, it's difficult to see anything and you cannot do it. So therefore, we tend to do everything possible to minimize blood loss. And they also found that things like cardiorespiratory problem, they are not as common as people used to think, because when you do laparoscopic surgery, you have to insufflate the abdomen, thereby causing tamponade of the chest. In other words, if you're doing it for somebody with already compromised cardiorespiratory state, you can reduce their venous return and cause further problem. But in this large study, there was no significant problem associated with cardiorespiratory complications. So if you look at this large study, which is more than 2,000 patients, it gives one a lot of confidence that laparoscopic surgery is as good, if not better, than open surgery for cancer surgery. So it's one of the evidence that is now been taken as a gold standard in laparoscopic surgery, in colorectal surgery, and it's therefore now widely accepted. So let me just summarize. The benefit to the surgeon in laparoscopy is that you perceive it to be a safer operation because you can see what you're doing. I don't know if anybody is watched, if you watched the laparoscopic procedure before, everything is transmitted on the television. Most of the TV these days are high definition. So you can see all the structures properly. You can see the pelvis, you can see the liver, every structure in the abdomen. And importantly, when you're dealing with a patient with dual pathology, for instance, if you think the patient has appendicitis, but you're not sure if it's ovarian cyst or ovarian problem, you can do laparoscopic surgery and then you'll be able to visualize it and see it properly, which is not something that you can do easily in open surgery unless you create a bigger hole. We know that the equipments are very good, so we are able to dissect very well. There are energy device equipment like harmonic scalpel, ligature that we use. And these are very good for fine dissections. They also seal the blood vessels, so there's reduced blood loss. So there's no need to tie the vessels while doing laparoscopic surgery. The vessels are sealed as you dissect. It's really good for training because when you're doing open surgery, you actually sometimes don't see properly. But whereas when it's all on the television, the trainee, the medical students, and everybody in the room will be able to see the procedure as it's being performed. Everybody is able to follow it. So overall, because of the little what we call the key holes, the postoperative pain is reduced. Patient may have undergone a longer duration in hospital, in theater, but their hospital stay overall is reduced. Most of the cases can now be done as day case or as overnight stay. The cosmesis is improved. Risk of incisional hernia is almost nil. And then from one or two papers that we've seen previously, there is improved survival because the immune system of the patient has not been disturbed too much. So on the basis of this, it's now actually almost become a gold standard to do laparoscopic surgery for every procedure that you can consider it for as the first choice. For the patient, we talk about the wound, which is very important because that's what they see after surgery. A small wound is definitely more acceptable to a patient than a large one. A small wound is less painful. A small wound makes the patient recover quickly. They have shorter stay. They can return to the activities quickly. And they have shorter risk of infection. So based on all this, it's my conclusion, and it's the conclusion of a lot of the proponent of laparoscopic surgery, that it is definitely more advantageous than open surgery. I don't know if you can see this slide here of this young lady of 70, one of my patients, 70 years old. You can see the scar in the wound in the middle. That is where the specimen was extracted. It's very difficult to know exactly what was done unless I mention it. It was a right colon cancer. The keyholes are on different sides. They've healed very well. But actually the scar you're looking at in the middle was a scar, the wound opened in order to extract the tumor. It's healed beautifully well. She's very proud of it. She stayed 3 days in the hospital. Ordinarily, for a right hemicolectomy for a 70-year-old, you'll be staying in hospital for about 7 days, maybe 5 to 10 days. So this is one of the benefits of laparoscopic surgery, and this is why we're saying that it is definitely much better than open. Any questions at this point? Does anybody want to come in? Yes. Okay. Okay, I'll carry on. This slide probably relates to, it should be Nigerian perspective. Really, I think I've got the answer. It was more or less to know how many laparoscopic cases are performed in terms of, in general surgery, in terms of appendicectomy, rectopexy, colectomies, anterior resection. So we're going to skip this slide because we know that we are just going to start doing them from now on, hopefully. You guys are going to be the the ones that will take laparoscopy or start laparoscopic surgery, because it's something that you have to do. How do you get started? The patients essentially are the same as the patient that you have for open cases. So any patient that you can do open surgery on, you should be able to do laparoscopic surgery on them, with one or two exceptions. The majority of the patients, as long as you can perform open surgery for a condition, you should be able to do it laparoscopically. Let's say somebody comes in with appendicitis or gallstone disease. Rather than doing laparoscopic cholecystectomy, you should be able to do rather than doing open cholecystectomy, you should be able to do laparoscopic cholecystectomy. The preoperative preparation is really not different from open surgery. Whatever pre-assessment you do for open surgery is what you do for the laparoscopic cases. There's no special preparation. In terms of patient selection, you may want to exclude certain categories of patients in the beginning if you think they're too obese or they have too much risk in terms of cardiorespiratory. Otherwise, the patient selection is roughly the same. So once the patient is in the anesthetic room, the pneumoperitoneum is usually set between 12 and 15. Normally, I like mine to be 12. This is the gas that you insufflate the abdomen with in order to cause this tension so that you are able to insert your port and the laparoscopic equipment. Carbon dioxide is the gas of choice. As you know, carbon dioxide is odorless, it's easily absorbed, and it's not, it won't cause combustion. So we use that a lot. Some areas use nitrous oxide, but in our center, it's usually carbon dioxide. So all these are standard with laparoscopic surgery. And when you partner with the industry, the set is brought in with a lot of these choices with it. Now, the instruments, you need to have a camera. We call them scopes. The camera can look at different angles. 0 degree means it looks straight ahead. 30 degrees means that it can look sideways. Yeah, so if you are performing procedure directly in the abdomen, so for instance, you're doing appendicectomy, you don't need 30 degrees. 0 degrees is good. If I'm doing a hernia repair, which is on the anterior abdominal wall, 0 degree is not very good for that. So I tend to use 30 degrees because you can look upwards without bending the camera too much. So these are all different cameras that will be available with the laparoscopic pack. And you can use a 5mm port or 10mm port. The cameras are there. If you use a 10mm port camera, it tends to give you a wider view than a 5mm. So creation of port means where you insert the instruments through. There are certain ports that you use. Again, they are available from Ethicon, from Applied, from different industries. As soon as you're doing laparoscopic surgery, they will definitely come in and look for you and want to partner with you. So you can have a 5mm port, 10mm, 12mm. It's very rare to have anything bigger than 12mm. You can have them in different lengths as well. If you're dealing with a very fat patient, they can be longer than the standard length. Otherwise, most ports are of standard length. Energy device, you can still use diathermy, which is common in most places. As a matter of fact, when laparoscopic surgery started, it was diatomy was the main energy device. Now you have more sophisticated devices like a harmonic scalpel, ligature, and so on and so forth. These energy devices are very good in the sense that you can use them for dissection and also for sealing of the vessels. So you basically can take out a tissue with minimal blood loss and minimal disruption of the dissection plane. You require a lot of other instruments like staplers, endoloops. If you're taking out appendix, you need what's called a loop, almost like a suture, to put at the base of the appendix. Staplers are used for cutting the bowel, dividing the bowel. It's similar to the staplers used in open surgery, but it comes in a endoscopic kind of laparoscopic fashion, whereas the open surgery staplers are shorter. Again, you can decide whether you resect your bowel while the specimen is still inside the abdomen, which we call intracorporeal resection. You can resect the bowel. You can now do your anastomosis while the bowel is still inside, or you can bring it out through the port, through an open incision, and then do what we call extracorporeal resection and then anastomosis. Other adjunct to laparoscopic surgery is endoscopic ultrasound scan. And this is used really by the liver surgeons when you want to find out where the vessels are. You can do endoscopic ultrasound scan. You can do imaging endoscopically. These are different level. It's not necessary in the standard practice. Definitely, you need retriever bags so that when the specimens have been resected, they are put in a bag before they are retrieved from the abdomen in order to avoid contamination with the ports. We talked about potential complications of laparoscopic surgery in terms of injuries. It's easy to avoid them if you know exactly where to site the port. You know where the inferior epigastric vessels are. You know not to go too deep into the abdomen, otherwise the port can go straight into the abdomen, abdominal aorta. You know the site of the ureter. It's always good to understand anatomy very well so that when you're dissecting, you're not dissecting structures that are difficult to feel. The bladder must be empty. It's easy to perforate the bladder if it's distended. So bladder must be empty before you put the ports in. Putting the ports in requires different techniques. You can either do it bluntly, blindly, which is not recommended, or you can put the ports in by doing what we call Hassan's technique, which means you do a small incision through the paraumbilical area and dissect the fascia and then insert the port in an open way so that you avoid putting the port in blindly. So some people use Veress needle, punching a needle through the umbilical area or through left upper quadrant, and then put the gas into the Veress needle to insufflate the abdomen before putting the ports in. Again, that's common, that's possible, but the risk of injury with various needles is quite high. The best technique recommended by the Royal College of Surgeons is the open technique. NIG device, you have to be conversant with them, use them safely, diathermy. If you are using diathermy or NIG device, you have to use it only on the structure that it is meant to be used on. If you look elsewhere and the NIG device is on a different structure, you can cause burns or injuries or damage or perforation, which may not be noticeable at the time of your surgery. So whatever device, whatever instrument you are using, you have to be sure that you have them in view or under the focus of the camera. There are a lot of various techniques for achieving hemostasis. The NIG device is one of them. You can put in swabs through the port to stop bleeding. You can stitch vessels laparoscopic to stop bleeding. So there are very many different techniques. By and large, bleeding in laparoscopic surgery, it's not common. In order to be safe, you need to make sure you put in adequate number of ports. And for instance, if you're doing an appendicectomy, it's required that you do 3 ports. Some people can do it through 2 ports. Minimum, you need your right hand and the left hand, and then the camera port. So you're looking at 3 ports. In very complex cases, you may need up to 4 ports or even 5 ports. You have to put as many ports as you think are necessary for the procedure. It goes without saying that the instrument you use, you have to be familiar with them. It's not, you don't use your scissors, for instance, inside the abdomen without knowing how they open and close. And above all, when you're doing laparoscopic surgery, it is stated that it takes longer. It's not a procedure that you do when you are in a hurry. It's not a procedure you do for a patient that is bleeding or a patient that is unstable. You have to take your time, stay calm, and it's really an enjoyable procedure for both the operator and the trainer and the trainees. And finally, we always say doing laparoscopic surgery does not mean that you have to finish the case laparoscopically. You can do what we call a laparoscopic assisted surgery. So that means you have dissected a lot of the tumor or the disease part laparoscopically, and then you now make a smaller incision to remove the rest of the specimen. Or if there's a big vessel and you're not sure that you can control it laparoscopically with the NIG device, you can do an open tie. So there are a lot of reasons why you should know when to convert to open. If it's not going well, if it's taking too long, if it's bleeding, if you're not making any progress, you should know that conversion to open is acceptable. It's not a sign of failure. I'll probably just skip this slide. It's again telling you the cases that have successfully undergone laparoscopic surgery. This is with diverticular disease, comparing them with patients who have open surgery. You have better cosmesis, shorter postoperative stay, reduced ileus. A lot of good things said about this in the paper done by Cleveland Clinics by Fazio et al. Similarly, this is something related to colorectal cancer. There's a lot of cases. from this center. Now we talk about the conversion rate. You see 20% conversion rate. Some people may say that, yeah, it's quite high, but it is not actually. A lot of centers will probably have 10% conversion rate. Conversion means you have not completed the procedure laparoscopically, so you have changed to open at some point during the procedure. So once you've converted to open, then it's regarded as a conversion. So 1 in 5 conversion rate is not too bad. And most of the centers have a higher conversion rate at the beginning. So when you start doing laparoscopic surgery, it's not a sign of failure that you are actually not able to complete it laparoscopically. You may at some point have to convert. You may be able to do 50%, then 70%, then 90%, and then eventually you're able to do everything completely, 100%. We now know that mortality from laparoscopy surgery is significantly low, the morbidity is low, and what was perceived to be inadequate cancer resection was not the case. This is justified by the average lymph node dissection that comes with a colorectal cancer specimen. On average, in this patient, they harvest about 12, which is very good. In open surgery, it is acceptable to harvest 8. So when you're harvesting more than 12, that is good. Again, similar argument regarding laparoscopic. So let's go on to what I consider to be that contributed to success of laparoscopic surgery, especially in the United Kingdom. So we know now that laparoscopic surgery is come to stay. A lot of centers are doing it. There are a lot of training centers available. From 2002 to now, there's been an increase in number of surgeons who have taken on laparoscopic surgery as their main specialty. Why this is going on? There's a program called Enhanced Recovery Program. Again, I don't think you probably have read about this, but it's something that came along alongside laparoscopic surgery. So Enhanced Recovery Program is a set of program identified or collated to make the patient's journey from preoperative period to discharge, make it very smooth. Essentially, you want a patient to come to hospital and have a coordinated pathway and recover fully, almost as if nothing has happened to them. That was the original plan, and that's still the plan. In order to do this, you have to have a good setup for it in terms of having a nurse or a dedicated team that are geared towards enhanced recovery. Patients are selected for laparoscopic surgery, and they will be told in the beginning what the pathway, what their journey will be through their hospital stay, throughout their hospital stay. So there's going to be more or less a patient education. We tend to give them protein drink carbohydrate drink before the surgery in order to boost their level of energy. And we tell the patients that they will need to mobilize quickly. They need to mobilize almost on the same day of the operation. And there is a program designed for them. So how many yards they need to walk in in the morning, in the afternoon, and in the evening. They are really motivated. We give them, we start them drinking on the same day of the operation. All the drains are either not used at all or taken out quickly on the following day. If they have urinary catheter, we remove them quickly, and then we take down the drip so that patients can start drinking and take control of their own recovery in the hospital. Again, this is very challenging because the patients are really supervised by dedicated nursing staff. And when you do this, you actually find out that patients can come in for major complex surgery, and within a day or two, they are on their feet. They're talking about discharge by the third day, and they can go home. This is to do with discharge planning, and again, probably not appropriate for this discussion. This is mostly where laparoscopic surgery is done in large centers. Patients have a dedicated nurse that they can call at any time if they have been discharged home early. So they can come back to the hospital if there's any problem, such as ileus or one problem or bleeding. And overall, this trend, which is called fast track surgery, is really to make the patient's journey and recovery from the hospital very, very smooth, almost like going to a supermarket to buy a product and then you take it home, and there is no, it's almost stressless. Stomach care is another aspect that is easily forgotten. When you do colorectal surgery, it's estimated that 20 to 30% of patients who undergo major colorectal resections end up with either ileostomy or colostomy. This needs to be addressed before they come into the hospital. They need to be taught how to how to change the colostomy or the ileostomy, and how to apply the bags in such a way that it does not add unnecessarily to the hospital stay. So I think we'll probably just give one or two examples of laparoscopic surgery before we go on to the robotic. I don't know if anybody wants to take this on of the trainees. This is one example of a patient that I asked one of my trainees to summarize for me. So this is a 38-year-old female who came in with gallstone disease, recurrent biliary colic, large BMI, and the patient needs cholecystectomy. Does anybody wants to look at this? I think in your current setting, you'll probably be open surgery, correct? Should I pick on somebody? Is there any general surgeon there?
Ayo.
Yes.
Yeah, pick on somebody.
General surgeon, Chidoze. Chidoze?
Chidozie.
He's muted. You're muted.
Okay, I'll unmute him. I've asked him to unmute. It's obviously, let me just see how good does. If I can unmute him. Or anybody that wants to answer while Chidozie is deciding what I wants to. Oh, I see, I can only ask to unmute rather than I can't quite unmute him.
Okay, okay. So nobody can answer back. Can
But
anybody
they can answer back, they can unmute themselves.
Yeah. Anybody here who wants to contribute to this? No,
Okay.
okay.
Kenneth,
So,
Kenneth Honor. Okay, go on. They're obviously not talking to
okay,
you.
okay. So this is a young lady, obviously, with a gallstone problem, and she wants a cholecystectomy. I was going to ask if it was advantageous doing laparoscopic over open for this patient, and the reason why. So if we do open cholecystectomy on this lady, the problems we're going to encounter will be her size, because she's quite obese. It may be a very large Coca's incision. She may have to stay in hospital for maybe at least 3 days or longer. It may be that after the operation, she may develop an infection, or if not, she may come back some months later and have incisional hernia. Whereas if this lady have laparoscopic procedure, she will have three ports for the dissection and 1 port for camera. The ports are going to be 2 5mm ports and then 2 10mm ports, which are very tiny. This patient will almost certainly be able to go home same day. And this patient will not need to be seen again, because we will not expect her to have any complications. No wound infection, no wound-related incisional hernia, and no adhesions, or very minimal risk of all those things happening. So my point really here is that this highlights the advantage of laparoscopic surgery over open surgery, even in a situation as benign or as common as gallstone disease. Now, this is a second case. Again, I've picked these simple cases to illustrate the benefit of laparoscopic surgery and to definitely stimulate you into thinking along that line and pushing for the development of laparoscopic department. There's a 26-year-old lady who is unmarried with background history of polycystic ovarian syndrome. In the past, she has been seen with lots of gynae issue. But on this occasion, she came in with a more severe pain, and you now think it's appendicitis. You need to operate on her. So this is a typical example of a lady who will benefit from a laparoscopic surgery for obvious reasons. One, you will be able to know that the appendix is actually where the problem started from, and not the ovary. Two, you will be able to take out the appendix with little or no disturbance of her pelvis, because she's primate. She's going to start a family, and it's very unlikely that there will be a lot of contamination when you do appendicectomy or laparoscopic for her. And thirdly, she'll be able to have the procedure done as a day case, and or maybe at worst overnight stay, and be able to go home the following day. Even if this is perforated, you can still do it laparoscopically. You are able to see the extent of the perforation laparoscopically. You are able to drain pelvic collections laparoscopically, and you are able to irrigate the pelvis laparoscopically. And finally, you're able to insert a drain into the pelvis laparoscopically, which still give her a lot of advantages than when you do a laparotomy for a perforation due to appendicitis. I hope these two cases illustrate my point. This is a view of laparoscopic that you see in laparoscopy. So in the past, actually, in 1990, for instance, or before then, in the United Kingdom, certainly when I started training, these two patients will have undergone open surgery, and they will have ended up with problems like risk of DVT, risk of wound infection, risk of adhesions, risk of wound related problems, and the longer recovery period, longer time off work. So finally, in order to be good at laparoscopic surgery, it's recommended that you either work in a laparoscopic unit, or you combine this with going to a training center where you can do simulation training. The gynecologists have perfected this in the United Kingdom, and it's the same technique really, whether you're doing laparoscopic for gynae or for general surgery. It's still the same hand-eye coordination that's required. So the training is essentially the same. So when you go to a simulation center, you can do it not on the patient, but on you can do it on in the laboratory, in a cavity as shown in the picture here. And this is connected to a television, and you work in a kind of apparatus that represents abdominal cavity. You'll be able to do a few things like picking up an object, putting it from one segment of the cavity to another segment. You'll be able to do suturing, you'll be able to do dissection, and you will see what you're doing on the screen. So these are all simulations centers. And when you do that, it's estimated that you improve rapidly by the time you come on to the operating room to perform it on the patient. It is definitely not recommended that you start performing surgery on a patient in the first instance without having adequate training or supervision before you start doing them. So this will be some investment required in order to do laparoscopic surgery properly. The philosophy is really about doing the same thing and doing it over and over and over in terms of what we call practice. Because when you practice, you get accustomed to the instruments. It's almost like playing computer game or PlayStation. The longer you stay on the game, the more the more skill you develop, you become better at doing it. So you have to repeat the same action time and time and time again. It's estimated that by the time you spend 10,000 hours, I don't know how many days that comes down to, 10,000 hours, you will have acquired what is perceived to be the laparoscopic skill. There's something called hand-eye coordination, tactile feeling. Like when you use an instrument to touch a soft object or a hard object, you'll be able to know the difference. And all this depends on your practice. There's no substitute for practice. Overall, patients do improve in dexterity. They improve in the time taken to achieve a skill when they have been in the simulation center and not just in the operating room. It's good to assist in the operating room, but actually doing it in a simulation center gives you a head start, and it makes you acquire the skill quicker. We talked about the complications and how to avoid the complications. It just means that when you are well trained, when you've understood your instruments, and when you've achieved or acquired the skill required, you're less likely to run into trouble. And if you run into trouble, if there is any complication unexpectedly, you are more likely to be able to resolve that easily and quickly. So in summary, training, practice outside the patient, and be aware of your limitation. When you need to convert to open, you convert, you don't wait at all. You don't, there's no pride in doing laparoscopic cases and insisting that you have to complete it laparoscopically if you're not making progress, or if there are problems such as bleeding, you convert to open. You do what is safe for the patient. I said all patients are able to undergo laparoscopic surgery, but in certain cases, if a patient is too obese, or if there are previous midline scars from previous operation, or if it's a very complex operation, complex surgery with a lot of, if the tumor is large or a lot of adhesions, or when you're expecting it's going to take a longer time, it may be that laparoscopic surgery is not not the best thing for the patient. So this patient may need to be carefully selected, or it may be that they will need to have laparoscopic assisted surgery rather than expecting to be able to complete it laparoscopically. And remember, it's a team game, so you need your experienced nurses, experienced assistant who is able to hold the camera for you, your anesthetist, your enhanced recovery nurses. So everybody needs to be on board. So when you have a laparoscopic center, when you're trying to develop it, make sure it's not just you that is being trained. Bring up a team with you. It will make your life easy. So that's enough about laparoscopic surgery. We'll move to robotic, unless if anybody has a question, feel free please to interrupt me. Otherwise, we can wait till the end of the lecture. I don't know if anybody's raised their hand for any questions.
There's nobody raised their hands here.
Okay. So now we've said a lot about laparoscopic surgery, about how beautiful, how good it is for the patient, how better it is over open surgery. Now we move into an age where there's something even better than laparoscopic surgery, and this is robotic surgery. We can move from open surgery to what we call keyhole surgery, and now to robotic surgery. There's no need to go over the advantages of minimally invasive laparoscopic surgery in terms of less pain, quick recovery, small incision, less post-operative problems, quicker return to work. Now, when you do robotic surgery, you find that all these advantages are also in robotic surgery. However, where robotic surgery has better advantage over the laparoscopic surgery in the areas of instruments, where in laparoscopic surgery, you probably limited in the number of instruments you can insert. Robotic surgery, you have so many arms. I'll show you a robotic procedure in a minute. There's so many arms you can, through a single port, you can have several arms and several instruments that can be deployed to do different procedures. Most laparoscopic centers have a HD screen, so the vision is quite good. But you're only looking at 2D vision. In robotic surgery, you have a 3D, which makes it easier for you to see what is around the structure that you're dealing with. So it's much better vision, and therefore the depth of perception is better in robotic than in laparoscopic. But when you're looking with the 2D vision, you don't know how deep a pelvis is. You don't know when you get to a structure. You may have got to the structure and injure the structure before you know it. Whereas in robotic surgery, all those problems are not there. And they're also restricted kind of movement in laparoscopic surgery because it's kind of a rigid procedure in terms of the instruments you are using. The instruments are they're not flexible, and they're not fulcrum. You cannot reverse it. You cannot bend it the way you want. Robotic surgery is like using your finger. You can move it to different sites once you are inside the abdominal cavity, unlike laparoscopic surgery. In laparoscopic surgery, you need your team to be skilled. I'm saying that you also need your team to be skilled in robotic, but it's not as dangerous as in laparoscopic. Whereas if your assistant doesn't know how to hold the camera, for instance, you are struggling all the time. In robotic surgery, the robotic eye follows you all the time, so there's no problem about holding the camera. And almost certainly, it's a lot easier for a surgeon who can be in his office and be performing the procedure remotely. So this is the robotic instrument. It was developed about 20 years ago. It's just beginning to be used commonly in most hospitals, at least in UK. But it's been around for a while, since for over 20 years. So you have the console, and then you have the robotic mechanical arms that will be in the theater with the patient. And then there's a remote console that can be anywhere in the office or somewhere which not necessarily in the operating theater. That can be where you can control the robotic arms from. So you can see the surgeon. So this console can be in a remote area, not necessarily in the operating theater. This is what the surgeon will be looking at. And this is the operating theater with you can see the various arms of the robot. We call it robot. The patient is lying on the operating table. You certainly still need to have a nurse there, and possibly have a surgeon to make sure that nothing goes wrong. But they're not active. The active person is the person who is directing the controlling the robotic arm from a console remotely. So this is a live case where the ports have been inserted in. This is a nurse who is available to, if the surgeon wants the nurse to insert extra instruments that can be inserted through the robotic arms. And you can see the surgeon who is not even scrubbed in a different location. So the procedure performed without anybody actually in attendance to at the operating table, except just to be available in case there is any any problems. So the way this happens is that almost like a PlayStation, the surgeon makes a movement. You want to dissect a structure, you make the movement in a console center, and this is translated to the robotic arm inside the patient. A movement that you make is actually not amplified at all. When you think you've run 100 meters, the robotic arm is only just done it in slow motion. So you can actually see it going slowly, even though your movement at the console center is quick, but the robotic arm is actually quite slow. So there's no danger of the robotic arm causing damage or going to tissue that it's not supposed to go to. There are a lot of joints. If you look at the arm, there are a lot of joints, and the arms can be moved in different angles, 360 degrees, 180 degrees. It can go anteriorly, posteriorly. It's the same way you use your hand, your fingers in open surgery. So I haven't got a video of the robotic case. My robotic colleague was unable to join us today. He had that on his computer. But again, this lecture is probably just for information, because I think the attention should be more on the laparoscopic surgery at this point rather than on robotic surgery. But where robotic surgery is useful, where laparoscopic surgery are difficult. So laparoscopic surgery, as mentioned earlier on, are difficult in obese women. They are difficult in deep pelvic areas, and they are difficult in complex surgery where you have a large tumor or where you have phlegmon. So all those areas are easily you can easily get to them through using robotic arms. And the vision is so good because it's a 3D vision. So when you, for instance, if there's a diverticular phlegmon and you don't know if it's stuck to the ureter or stuck to the ovary or bladder or uterus, you will be able to, through the robotic dissection, you'll be able to see the plane. You'll be able to dissect it much easier than when you're doing it laparoscopically. Clear advantages, almost similar to what you get in laparoscopic surgery. The advantage is, again, because there are little or no trauma to the patient. So there's reduced pain, there's less metabolic reaction to injury. Recovery is quicker. One thing I forgot to mention is suturing. In laparoscopic surgery, it's almost difficult for everyone to do suturing, especially in deep places. In robotic surgery, it's as if you are using your own fingers, so it's easy to do laparoscopic stapling and suturing robotically. So this is a big advantage using robotic surgery. It has a short learning curve. It's easy to train in robotic surgery. It's easy for trainees to understand it better than laparoscopic surgery. But the disadvantage really is that it is expensive. It is very expensive. Most hospitals are not able to afford it. So the one we have in our hospital is on a lease system from the industry, and they rely on us doing cases jointly with the urologist, with the gynecologist, in order to have a high utilization. So I hope that gives you kind of a taster to what robotic surgery is all about. It's not something that is probably recommended at the moment, except in centers where you want to do complex major cases. But it's definitely something you should be aware of, because I know when the technology improves in 20, 30 years time, it's going to overtake laparoscopic surgery. I better stop there. Thank you very much. I'll be happy to take questions or feedbacks or any responses.
Okay, Ayo, thank you very much for the wonderful lecture. I'm not sure who's older, me or you, but but yes, when I was training, appendix was open, cholecystectomy was open, but now I have trainees who've never done an open cholecystectomy. And I have trainees who hardly know what open appendicectomy is. So it's now become, laparoscopic cases have now become second nature. And yes, I think that I was in Newcastle as a trainee when the classic trial was taking place, and that you alluded to, and my consultant took part in the classic trial. And I think that what you rightly said, in those days, the reason why they had a lot of more complication was the fact that people felt that if I study laparoscopically, I have to finish. And that wasn't true. But now that people are beginning to realize that if I'm working, open up, it's safer for the patient, and that's what you want. Now, the last part of your statement about robotic surgery, yes, if they improve it, do you really think robotic would take over from laparoscopy?
I think, yes, that is, I think we are at the stage that laparoscopic surgery was in relation to open surgery. I think when laparoscopic surgery started, I remember I worked with a consultant who said, oh, he could do cholecystectomy much quicker than laparoscopic, and patient will go home the following day. So there's no point doing laparoscopic. But now, I mean, everybody is converted. You cannot justify doing open cholecystectomy unless there are reasons for doing it. So as the technology improves, I think, and the cost is down, I think robotic surgery will take over, because it's less tasking for the surgeon. You do a lot of pelvic surgery. I don't think you want to do a deep pelvic tumor laparoscopically or even open, when you can sit down in your office or in a consult center and you can have it done easily, robotically. It may not be true maybe for things like appendix or gallbladder or those sort of cases, but certainly in complex situations, it will overtake laparoscopic surgery.
Yes, I think I agree with you in terms of the deep pelvic thing, because I think that's where they've seen the most advantage. Yes, you're right. I mean, when I was an SHO, when I saw the first laparoscopic hernia operation, and I just thought to myself that day when I saw it, why are these people making life so difficult? And I did promise myself that I would never do laparoscopic hernia. Obviously, years down the line, I do that all the time now, and it's easier. So you're right about that. But I think the main difference, though, between laparoscopic and open is that it's still instrumentation. It's almost the same operation, but where the surgeon is. And I think we can say for the pelvic operation, low rectal cancers and things like that, and possibly actually even rectopexy. But I'm not quite sure about appendicectomy, even lap chole.
But I think maybe in years to come, we won't even be doing appendicectomy anymore. They will just be treated with antibiotics.
Antibiotics, yes. I've got a question here. Somebody,
Sure, yeah.
somebody, Nuruddin Akimbami
Okay.
has said that thank you for your lecture, sir. I would like to know indications for conversion to open,
Okay.
also contraindications to laparoscopic surgery. He is confessed that he missed that part of your lecture because you spoke about it.
Yes, that's actually important to emphasize that. I think we briefly mentioned, you also mentioned it, for sure, that people should not feel that they have to complete a procedure laparoscopically. Converting to open is not a sign of failure. It may be there is instrument failure. For instance, you haven't got the right equipment for doing the procedure that you want to do. You have to convert. If you encounter bleeding is one of the main reasons for conversion, at least in my practice. I don't like blood at all. Once there's a lot of blood and I cannot see what I'm doing, I mean, there are other ways of controlling the bleeding. But if I cannot see, then I don't persist with laparoscopic surgery. The other indication intraoperatively is if there is an unexpected finding. Say you think it's a straightforward right hemicolectomy or left hemi, and normally you will have staged the patient very well. But if the tumor is fistulating into, say, small bowel, or if the ovary is stuck to it, and if there is an unexpected finding and you cannot explain it, you have to convert and identify it properly. And one of the other problems that we encounter a lot is, especially with the trainees. I keep saying that because we allow trainees to use laparoscopic surgery a lot. Most of them are now actually better laparoscopically than open. If they think they might have inadvertently injured something else and they cannot see it. So for instance, if you're dissecting and you have a serosat tear and you cannot see, you cannot find a small bowel, rather than assuming that, oh, it's okay, you have to open up and find that hole and repair it. So those are the indication for conversion. And obviously, if you're not making progress, a procedure that should take like 1 hour, 2 hours, you're there for double the time. It's not good for the patient. It's not good for the anesthetist. If you're not making progress, yeah, definitely convert. The second part of the question is patient selection. This is, generally speaking, it depends on your level of experience. In the beginning, you may want to select simple, easy cases to do. But as time goes on, as your confidence develops, you actually find out that there's no need for patient selection. You can do laparoscopic surgery for any patient that you consider surgery on, apart from I keep saying it, if the patient has undergone multiple previous laparotomy in the past and you think there's going to be scar tissue adhesions, then you don't need to start laparoscopic. All you're going to do there is to cause more damage. Other than that, we tend to not recommend laparoscopic for patients who are elderly with cardiorespiratory problem, because you cannot put them in a head down position for a long period of time, and you cannot give them pneumoperitoneum for a long period of time. So you have to carefully select those who will be able to tolerate pneumoperitoneum and head down for a prolonged period of time. So yeah, that's my response. By and large, every case can be done laparoscopically, but carefully select them.
Thank you. And I think that I'll just add to that if I identify that the case is going to be difficult, I tell people right from the word go that if I'm on this case for 20 minutes or 40 minutes, and I'm not making progress, I'll convert. It's not really for the information, it's just to let me know that I have a stopgap. Okay, that look, we're not going to do 2 hours and then suddenly find. So I do that. And the other, about 4 or 6 weeks ago, the gynecologist called me to come and help them out. And they were doing something I wasn't really keen on right from the word go, but they wanted to do some ovarian cyst out in a woman who had a previous pouch. And there was going to be adhesions in the bottom end, but they wanted to do it laparoscopically. And they called me to come and obviously separate out all the small bowel from a previous pouch away from the things. I did voice my unease about that. And when I got to theater that day, I said to them, listen, 20 minutes tops. If I'm still faffing around at 20 minutes, we're going to stop, convert to open. And actually, as it turns out, I was able to separate small bowel, everything off the place. So I think it's important that conversion, you need to think about it. One of the things I would add, though, is that bowel obstruction, particularly if there's so many loops of bowel, then I'm always very cautious about not wanting to put a laparoscope in.
Yep.
Dr. Shunaya, you've got your hand up.
Hello, sir. Good afternoon, sir.
Good afternoon.
Thank you, Mr. Oshowo, for the presentation. It was very lucid and very informative, sir. When you were talking about laparoscopic appendectomy, you mentioned that when it's ruptured also, a laparoscope can be used to lavage the pelvis. In a case when you have generalized peritonitis and there's pus everywhere in the abdomen, could you also do thorough lavage with laparoscopy? That's my question.
Thank you very much, Dr. Shunaya. It's good to hear your voice and also to see you. And congratulations. I know you've.
Thank you very much, sir.
Thank you, sir. You've advanced now. Now, it will definitely depend on the level of your expertise. A lot of my trainees will, like I said earlier on, they're better off doing laparoscopic than open. So even when there is perforation, when there is pus, they will still go ahead and drain the abdomen. They will lavage the cavity and put in drain rather than doing laparotomy. There is always a question of whether you are able to drain maybe sophrenic abscess or abscess close to the spleen area or intra-loop abdominal abscess laparoscopically. It's subjective, but it depends on the expertise. And again, if you think you're not making progress, the patient safety is paramount, you convert to open. In my hand, I would rather do it laparoscopically, drain the abscess, do washout and leave drains, than do a laparotomy because patients will recover quicker. In fact, my visibility is better laparoscopically than doing open because I can see the liver, I can see where the pus is, I can rotate the patient, move the patient head down sideways. I can put a lot of fluid inside the abdominal cavity. I can move the small bowel up and get into the pelvis and then wash it up properly. But if it's not something that one is confident in doing, then I suppose you can do it open. I don't know if that answers the question. So basically the answer is level of expertise. Simple cases, do it laparoscopically. If it's complex and you cannot deal with it, then do it open.
Yeah, I think you're right about that. I think that you can do a thorough lavage of the abdomen laparoscopically. I probably think you can do it better laparoscopically than open anyway. Because for you to do as clear a lavage open, you need an incision that's quite big. So I think you can do it laparoscopically to do 4/4, and we do that all the time. and just keep on pouring fluid until every quadrant is clear. Any other questions? So, Dr. Shonaya, just coming back to you, since you started working as the Oga person, how easy is it to start up a laparoscopic program in Nigeria if you wanted to do? Because I think you weren't here last week when we we're going to
No,
have.
I wasn't.
But one of your, I think the two of the residents said there were probably only 2 people in UCH who do laparoscopic surgery. And we apparently the limiting thing is always cost. But how easy is it to set up?
Well, I don't know exactly, sir, but I know some centers are doing laparoscopy very well. With training also, I know Ife does it. University of Hospital Ife does it very well, and they are training. They're training to do that too.
Do you know who's paying for it?
I'm not sure, sir. I don't know. I don't know. I don't know. I don't know the cost of the patients too, but I know they do it for patients, endoscopic, laparoscopic surgeries, biliary surgeries, ERCPs, and all that. They do that in Ife. Even Lagos too, Lagos University also does too. But I know Ife is the go-to center for government training, yes.
Are you serious?
Other centers are usually private, but of course that's for patient care, not for training.
Oh,
Yeah.
see, so
What's his name? Professor, what's his name? Alatishe. Yeah, he's quite good. I was at a conference with him in Lagos, and we demonstrated a right hemicolectomy together. He's quite competent. I think most of his cases are done laparoscopic
Yes.
way. So
that's pretty good. So, but somebody must be paying for it.
Yeah.
Because it can't be the patient. Hello?
Who pays for it?
I'm not sure actually. Patients may pay some, maybe I don't know. I don't know how the payment
How they
done.
funded?
How it's funded exactly. I don't know how it's funded.
Okay. So UCH, obviously you mentioned Ife and Luth, but you didn't mention UCH.
And we do it in UCH, but the volume is not much, sir.
Okay.
And basically, I think it's cholecystectomy and appendectomy that we do laparoscopically. And it's mainly 2 surgeons that do it.
And so nobody does colectomies at all?
No, not laparoscopically, no.
No, okay. Any other question, anybody? Okay, that sounds great. No further questions. Well, this is the last lecture in this series. I've said that please fill your feedback forms so I can release the video, but also that I'm going to send you, all of you, another questionnaire to fill regarding this year, which I really need all of you to fill. Okay, and on that questionnaire would be what you want to do, whether we should continue it. And I think that in order for for us to be able to take that forward, we need to have most of you filling it, because there's no point only 8 people filling it. We don't know whether it's representative of this. So the topics we're going to talk about the next time around is going to be dependent on what you guys feel, how we're going to run it, because I'll give 2 or 3 different scenarios of how to run it. Well, the way we did it, or to actually do something more quarterly, that is an all-day thing that is also based on specialty. So all those things will come in the questionnaire. So I do need you guys to fill it, all of you, before we restart, if we're going to restart. So I think all of that will be in your hand, but it's really totally dependent on you filling the feedback, the questionnaires for moving forward. Okay, and obviously there's some that I'm going to show. Then after that, obviously you filled initial questionnaire before we started, which I've noticed is I haven't actually quite shared the outcome of that. And I'll share the outcome of that when you've done the second one as well. The second one, while I think the feedback questionnaires are anonymous, we still know who fills them. So I'm going to send it to everybody who's definitely filled it, and I expect you to fill the second part. And then I'll just share all the outcome. And then we'll decide whether we're going to go forward with this and when. Is that clear with everybody? Okay.
Very
Yes,
clear,
sir.
Wonderful.
Very clear.
Okay. So those who haven't filled the feedback forms right now, can you fill it? And then we should meet sometime soon. And Fumi, I'll get the actually Fumi, I didn't know Nuruddin is there. I saw this lady earlier, but she's disappeared. I'll put the date out for the audit group in the next 2 weeks.
All right, sir. Thank you, sir.
Okay. Thank you very much, everybody.
Thank you very much.
Thank you. Bye. So, Ayo,
Bye-bye.
thank you very
Yes.
much. Thank you very much for the lecture. It's wonderful. I learned a lot. Oshogoni.
Thank you very much. Hopefully
Thank
we
you
can draw the next timetable and then see what the response is as
Yes.
to
So I think what I'm waiting for is send out a questionnaire to them so to know how we're going to move forward. And then hopefully in the next 2-3 months, we can restart again and see people have already started asking, that's the lecturers, when the next one is going to be. So I think there's interest on the lecturer's side. So it just now depends on the residents if they wanted to continue.
Yeah. Okay.
Oshogoni.
Thank you very much. Bye,
Okay.
everyone. Yeah.
Bye, everybody.
Yes.
Bye, sir. Thank you, sirs.
Thank you. All. Bye.
Yeah.